That the cave diver one. I love the heart flow.
Okay,
That was art. I saw him so.
welcome. Good job. Getting here. I think I have to apologize to everyone. In December, when we had no snow, I was like so worried. I was like, please, Lord, let us get some snow.
The answers will delay.
Answered prayers right here, it's happening. So it's good. Good. For the summer, we're not burning up in wildfires, right? Not so much. 6:30 or 7 in the morning. And just a life lesson, people, when you go to buy your first house or a house, and you're buying it in the summertime, think to yourself, what does this look like in the wintertime? What does my driveway look like in the wintertime? And maybe don't get one that's an incline that zips you into this busy street. You gotta be out there when one snowflake falls, or there's no stopping, you're just backing up and you're coming out no matter what. So just try to remember, what does this look like in January and February and March and April and maybe May in Montana? If you live in Albuquerque, probably not a problem, but here it is. Okay, let's start with prayer and then jump into what's happening today. My ear is plugged, so if I cannot hear you, just speak loud. I cannot get it unplugged. Trying all the things. Okay. All right. In the name of Father, Son, and Holy Spirit. Amen. Ooh, thank you, Lord, for getting us here safely. Golly. Pray for everyone who's out in the cold weather for their, they don't have shelter or heat. And all those who work outside, just pray for their protection. Pray for my little niece who's maybe having a baby today. Thank you for that. Just help her and help her husband, help my sister, all that, through this beautiful thing. So, surround her with great nurses. Let's pray for all our friends and family, wherever they may be. We just offer them up to you, Lord, for your protection. And we thank you for them in our lives. Amen. Okay. Let's talk about what's happening this week. What is happening this week? Story stuff is happening here and in lab, so that's fun. Oh, skill videos, how are those going? So Tuesday, people. And that uploaded before your start time, your lab. Thursday, or your start time. Thursday. And then, once I have them, then we have a week for everyone to watch and reply to them. And you're just gonna do the little audio reply, because I want to hear your beautiful voices, how you give feedback, like what went well, and one thing that you noticed that could have gone better. Okay. Yep.
Next.
When is that happening? Next week, not this week, next week, so, okay, next week. But I need you to be looking forward to that because yeah, you wanna get ready. Let's get ready. So tell me what skills, so how it's gonna work, kind of like last year. We're gonna meet, but instead of doing it 4 times, we are going to meet next Wednesday, very early. 6:30 start time. Sorry. Shout to each of the classes. And I'm not using all your time for lab. That's how I can do this, because I'm only seeing you for maybe half an hour during your regular lab time next week. And that will be when you actually come in to sign off your skill sign off. Does that make sense? So during your regular lab time, you'll sign up for your skill sign off portion. Everyone else will be meeting, everyone will be meeting on Wednesday at 6:30 upstairs. Okay? We'll go around and do like little stations where you're looking, feeling, touching, boop, boop, boop. You know, don't change things, but you know, you gotta get into stuff sometimes. Okay? All right, so what kind of skills might we have?
Oh, I was just wondering, do we have a written lab exam like we did for prelims?
Well, it's written, but you're going around, that's what's happening Wednesday.
Oh, okay.
Yeah. So you'll be going down, writing down like what you see and how you do this skill and what is this and what do we set this to and for complications, you know, all that. So yes, there is the written portion that's happening Wednesday. Then the skill sign off portion is just during your usual lab time, but you only are there for when you sign up. So if you're at 9:30 to 12 person on Tuesday morning, sign up sometime during that time. You come in, pull a skill out of the happy cup, demonstrate that for us. Okay. So what could those skills be? Yeah, just roll them off. There's a couple of them. Yeah.
I was gonna say the PCA.
Yeah. Oh, good. 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 If I could, I'd have you all do this. Yes, I could. Yeah. PCA for sure. Primary and secondary. IDs. Any questions? Learning this week. Vaccine, but also have you all do this. Trach care, another thing we're learning this week. Oh, staples and sutures. That's resin, she can put more sutures in there for us. What else? What am I missing? That's it? Yeah. Oh, yeah, pulled up, yeah.
Should we do sterile gowns?
No. Like the Oreo, yeah, I don't really have one that's perfect to reuse again. Seems like we're missing one, yeah. Nope, that was last year, but good job. Holy catheters. Listen, never go away. Never go away. Never go away. Yeah.
The second line.
Oh, yeah. Oh, my gosh. Yeah. There you go. Central line, blood draw. There you go. And central line dressing change. Yeah. Maybe. Yeah. Drains. Yeah, drains. Caring for drain. Yeah. Yeah. Those are actual skills and all those things I will ask you about. Even if you don't have that skill. Good. Yeah. Yeah, like I guess. You can do it. Questions? Have coffee ready to roll at 06:15 on Wednesday. Wow. Yeah, so this week is fun. We get to learn lots of things that you gotta know. Oxygen modalities, all things respiratory, and maybe G's. And then suctioning and care. Yeah, those are big, those are good. Yeah.
For the drains, what would we be doing? Or is it out?
So Penrose, Hemovac and JP drains, how we clean the dressing around them, the sites around them, how to empty them. Yeah. You'd be looking for, the little Penrose, looking for the little safety pin. That one's draining directly onto that pad, so it generally requires a lot more changing than the other ones, because it's closed. Those two others are closed systems. How they have suction or no suction applied to them. Good. Other questions? Okay. Peripheral IVs. Or the dilemmas, and I signed you off, but I'll also signed off on. Okay, so. May as well. All good. Anything else I'm forgetting? We have questions about. Use your lab tickets or your study guides. Look over your skill sign-offs. Those are found in a binder in the classroom or on Nursing Central. It's kind of nice to look on Nursing Central because it gives you the rationale. We just take the rationale portion off to make our checklist. But it's kind of nice. It helps you remember maybe why you're doing it, the rationale. Okay. About respiratory today, I'm going to kind of focus on pediatric respiratory conditions today, and then Wednesday we'll talk about upper airway disorders, and then next Monday lower. So obviously if we are spending 3 classes on respiratory, this is a big deal. Yeah. Okay. So let's talk about it. Let's review. This probably seems, yeah, like review, but it's important, especially when we're identifying what is an upper respiratory, what is a lower respiratory, what is an infectious respiratory disease process. Sometimes they can be both, right? So upper respiratory tract includes anything in the nasal cavity, the pharynx, and the larynx. Larynx is the voice box, which is kind of the dividing point. After that, then we're all talking about lower airway stuff. Okay, so that would be the trachea itself, the bronchus, the right and left main stem, the bronchioles, and then the lung tissue itself. Alveoli, lung parenchyma. Right? So if I'm talking about, I'll do that in a sec. The RN recognizes that which process occurs as oxygen and carbon dioxide is exchanged at the level of the alveoli. Perfusion, respiration, diffusion, or ventilation. Want to take a stab at it? Kind of seem similar. They are. You're right. Anything you can kind of get rid of? This is all about. Do we think this is perfusion? Okay. Do we think this is respiration? Okay, diffusion. Okay, and oxygen, oh, sorry, that's not even on there. Sorry, ventilation.
Can I just already say that one?
Okay, all right. Okay, so this is actually, respiration. So perfusion is like the blood flow to the alveoli, right? So we need that, and sometimes that is the issue. Ventilation is the air in and out of the chest, just the air movement into this negative space and then out again. Diffusion is actually how the oxygen and carbon dioxide come across there. That's the process. But when we're talking about oxygen and carbon dioxide, we call that respiration. So those terms kind of can get confusing. Respiration in the whole process, I guess. Okie dokie. Right, before I go to the next slide, why don't you tell me, what are all the things we use to assess the respiratory system? Like when you think to yourself, gosh, I'm gonna do a focused respiratory assessment. What are you doing? What are you asking? What are you looking for? What are you listening for? What are you doing? We'll review from an old assessment base.
Listen to the alarm.
Okay, so we're gonna listen, and what are we, when you're listening? What are you listening for? Abnormal breath sounds, right? Or clear breath sounds, like that tells me something, right? Good, and this can affect the upper, the lower, the lung tissue itself. All right, so what do we call it when we hear something different? Instead of clear to auscultation, we say we hear. Yeah, say it. Good.
Adventitious breath sounds.
Good. Adventitious. There you go. What might those be? Say it loud. I gotta plug you.
Strider.
Strider. Awesome. Okay, so what is Strider indicating? And where do we hear it? What's it say? Is it upper or lower? Upper. Awesome. So this is above the larynx. What does it sound like?
I put this one.
Yeah, high tension is good. Is it advantageous to have an adventitious breath sound like Strider? Is it a good thing to have Strider? No. No. Strider indicates either obstruction or closing of the upper airway. Right, either due to inflammation, mucus, a gumball, something sitting in there, and you're hearing this. That should get your attention. That is not a normal sound. And the most important thing when we talk about A, B, C's is what? That's what you're gonna lose. So that is a serious sound, right? So that should get your attention. Awesome. Good job, Strider. What else? Wheezing. Okay. Where do we usually hear wheezing? Upper or lower? Lower. What does that sound like? Yeah, musical. A bit softer, sometimes an exhalation rather than inhalation, but I would be hearing it down here, right? And it can be an indication of narrowing of the trachea and bronchus and bronchioles themselves, right? So the air moving through a tight little passageway, it's like when the wind is blowing around your house and it's sneaking through like a little barely open window. It's going through a narrow space. Go through a tunnel and wind is going through there like a narrowed space. That's what we hear. Lower airway, musical sound, often on exhalation. Indicates narrowing. Usually of the trachea, bronchus, bronchioles. Awesome, keep going. Crackles. Where are those heard?
Bottom of the lungs usually.
Yeah, lung tissue itself, right? And what is that indicating?
Moving the lungs.
Yeah, accumulation, right? Because it can be like bacteria or it can be fluid, you know? Lung tissue itself there, right? You know, or like a pneumonia. All right, anything else?
Oh, no.
Yeah, bronchi. So. That.
It's like her on expiration. I actually heard it in clinical,
Yeah,
on the medical floor.
and what does it sound like? Can you describe it?
And then they breathe out and it's like a zzz,
Mm,
rubbing.
yeah, kind of like a snoring sound. Kind of a deeper kind of snoring sound. Not really musical, not high pitched, not, yeah. This is indicative of like accumulation within the big airways. So I'm talking lower trachea, and right main stem, left main stem. Even like the bronchioles. Often it will clear if they cough. You know, if they're like, get that out of there, then you listen again. Oh, you don't hear it. Or when we suction, it's gone. Like, oh, okay, so kind of a snoring sound. Okay, so accumulation, maybe secretions in the airways themselves. So when I say that, I mean like, yeah. Bronchus, bronchioles. Yeah, what was your patient was in for,
Influenza.
there you go. Very good. Yeah, good. All right, everybody okay with that? What other things are you looking, listening, asking? Respiratory assessment. Very first thing, usually we say, we want to look at our airway and say, do you have a patent airway? Do you know how to check patency on an IV? How do you check patency on an airway? Sure, coffin might,
A lot of times you can just tell just from the sound that you see on the person.
yeah, right, so you're looking, right? You're observing and you're like, oh my gosh, do I see their lips swollen out to here because they're having anaphylaxis? Or does their mouth look normal or do they have like cyanosis around there? So you're observing this, right? And then if they're able to talk to you, cough, swallow, gag, you know, those kind of things are telling us that we have an airway. And then what other things would I be looking at the mouth itself? But what else? What is telling me that like, yes, they have an airway and now we're moving into breathing? What kind of things am I looking at? Yeah, good. So actual chest rise. Is it symmetrical or asymmetrical? What else? What are your vital signs? Like you're checking. Right, right, you're counting those breaths per minute. You're looking at that chest rise. Are you also looking at,
Retraction.
yeah, good. So is there something else that's helping this person breathe in that air or exhale? So are they, using all muscles like the sternocleidomastoids and their subcostal retractions happening? Like, are they using those muscles to get breath in or out? Is that a normal thing? No. So that should get our attention. So you're looking at that. Little babes, that's a bad sign, right? Nasal flaring. They're using those little. And something is happening. That's not a normal finding, right? Keep going. What about, we talked about rate, but what if they're like. Or. Yeah, right? Is it shallow or is it deep? Is it a combination of both? And then effort, that's what these are. Rate, depth, effort. What is their posture? Are they sitting upright in a tripod? They're not leaving that position, because if they do, they're not gonna make it. Or are they so exhausted that they're like not responsive in bed? So LOC, level of consciousness, posture, color. What do they look like? Are they ruddy, red, sweaty, diaphoretic? Are they cyanotic, pale, mottled? What do they look like? What other things do we do? What did you say? How much oxygen is bound to the hemoglobin? Anything else?
Paprika.
Yeah, good. Yeah, what's normal? Yeah, less than 2 seconds. Good. Touching that, looking for blood return. If it's prolonged, that could mean that we have a perfusion issue. So often we think about air movement, oxygen movement in and out, but it also, respiration also relies on blood flow to the alveoli. That's how that gas exchanges, right? Right around the alveoli, it has all the capillaries. That's how we get it in and out of our blood system from what we're breathing in. So if we have reduced blood flow, we will have reduced gas exchange. The old blood clot sitting in your pulmonary artery. That's a perfusion issue, right? Good job. Anything else? Back to the old toe. You ever taken care of someone who has a round barrel chest? If their AP diameter is not 2 to 1, it is round, round. my gosh. And I see that, oh my gosh, did this person have COPD? That's what we see, big barrel chest. What type of COPD we're talking about? Okay, so the actual physical structure of chest. I have had trauma, broken ribs, I seesaw happening. So do I have my ribs moving differently than just normal expansion? Increasing and decreasing with airflow? We have flail chest where a chunk of your rib is not connected anymore, it's going the opposite way. On babies, when they're in distress, we'll see the seesaw respiration where their little belly is just working opposite of their chest movement. Like, is that a normal thing? No, that should be getting our attention. Grunting in a baby. It's like exhalation. Like they're working hard to get that breath out. All those things should get our attention. Okay, so workup breathing, effort, depth, rate, color, posture, LLP. What happens when people are hypoxemic, have low levels of oxygen? Anybody ever answer this, but experienced or seen someone have an anxiety attack? Are they calm? No. Usually anxious, irritable, like something's happening. Scary not to be able to breathe, right? If anybody has asthma, you know what this feels like. It's scary not being able to breathe. So we can see that. Or as our CO2 levels rise, so that's like low oxygen, but let's talk about high CO2 levels. People get stuporous, lethargic, not responsive. So that's what you're looking for here. You're like, what is my patient's alertness? Orientation? Are they confused and irritable? And I look up and I can see that their SAT is 84. They're like pulling off stuff, and you're like, oh my gosh, we gotta get their oxygen back on and get it up. And that subsides once we get their oxygen mask back on. Okay, so all of that is what you're assessing when you're going into that room and looking at your patient. And then we have other diagnostic things that we can do. So O2 sat monitors, you know that. You guys know the on monitor, because I don't know, when you learn this, you just have the finger probe, right? So you know what this form is. On our monitor, no. Most monitors, it's a yellow waveform. And then it gives us our O2 saturation here. This is called a plaque waveform. Good to be able to see that, because if I saw something that looked like this, I would not take this reading. This is not a good plaque waveform. This is not actually telling us accurately what our O2 saturation is. So it's good on the finger probe, you can't see the plaque, but up on monitor, you can. So if you see like any straight edges like that, or like squares, you're like, that's not a normal plaque. It looks like a little mountain range. When you see that, you know that that's an accurate plaque. Otherwise, you don't know if it's truly accurate. Okay. Good. This little thing down here is an ABG needle. So we talked about this last week. Continue to incorporate that into our assessment here. This is like a spirometry or pulmonary function test. Anybody have asthma? You've probably done these kind of tests to see like tidal volume, exhaled, inhaled, forced vital capacity, those kind of things. This is a little chest x-ray. You don't really learn how to read them, but I would recommend that you pull them up. The more you look at them, the more you can kind of identify issues. So this little guy, you can see the little heart sitting right here. little liver, but what's this? This is like accumulation in the lung space. Okay, and then what is this? Yeah, urine specimen, or for this, sputum, right? Yeah. So we'll talk about how you, well, tell me, how do you get a sputum specimen?
Make sure they clear like deep in the lungs, it's not a spit, it's from right back in.
Right, it's not just saliva, we're trying to get it from way down deep. So they have to like, yeah, that's exactly what we're gonna do, like, you know, knock a loogie into this cup. But first I'm gonna rinse out your mouth. And I don't want you to like spit the saliva in there, I want you to get it from down deep. What if they're not able to do that? They're like, sorry, can't get it, because can't cough. Yeah, so we're gonna learn how to do that. Okay, so you will see, you know, I have a lot of soapboxes, you benefit from that, hopefully. One of them is suctioning. Why am I so crazy about it? Because it comes down to this. You have a big old mucus plug sitting in your airway, you do not have a patent airway. No air can get in or out, or easily in or out. So sometimes that means us going down to clear the airway. So we are not going to be fearful of that. You are saving their life, right? There is no fear in any of these things. We just have to know how to do them and do it. How would you know if someone needed to be suctioned? What do you think you hear? What do you think you see?
Feeling, we're having a hard time breathing.
Yeah, so that effort, increased effort, right? So their posture might be up. They might be using those substernal, like their muscles to breathe. What do you think their rate is? Getting up, you know, because they're working to get air past this like narrowed space. Yeah, Joe, what were you
A
gonna
lot
say?
of coughing.
Yeah, you might hear audible secretions. Maybe you know that they have all these secretions and they have been able to cough sometimes, but not right now, right? Or maybe they're coughing, but they just can't get it up. Yeah.
On pediatric inpatient, there was like a little lymph node and she had RSV. And we were going there and functioning because she was just having lots of like substernal retraction.
Yes, yes,
And like they suctioned her before she ate.
Yes.
Breastfed so that she could.
yes.
Nutrients and she could.
Yes, you can't breathe and eat at the same time, right? Yeah, and that's kind of important. Yeah, so clearing that airway so she could breathe while she is breastfeeding. Yeah. RSV is a scary little business. Is that their little airways like your size of your pinky, not too much inflammation or secretion is needed to block that airway. So like RSV, flu, everything is very problematic for a little bit. That's why we are proactive about good hand hygiene and vaccines. Because they don't have a lot of wiggle room, right? And they breathe through their nose until what age? They're obligate nasal breathers, right? Nose breathers until 6 months. So they have to clear that. No way that you can breathe or you can breathe. Yeah. Good. Good. So just hearing it, seeing those like labored breathing patterns. Cyanosis, increased O2 sat, all of that is saying like, let's clear this airway. Let's suction it out. Okay, awesome. All right, the patient is admitted. Oh, here we go. For evaluation of complaints of difficulty breathing and a sputum culture and sensitivity is ordered. Which of the following are appropriate when collecting a sputum specimen? You tell me true or false. Prior to collection, patient should rinse their mouth with water. True. Collection should be obtained before the patient goes to bed. Hey, like, we'll come back now. Okay, encourage patient to take a deep breath in and out, cough before expectorating sputum into the sterile container. Yeah, we're trying to get way down deep. We have to take a big deep breath in and out, cough, and then get it out. Obtain the specimen after antibiotics are initiated. No, false. You're just smart. Remember, you had it cultured before Start antibiotics. If the patient is not able to cough up sputum, the specimen cannot be obtained. False, because we can go down there and get it ourselves. Yeah, okay, so collection should be obtained before patient goes to bed. Usually we want it first thing in the morning, on rising. Good, test. The nurse prepares the patient for which diagnostic procedure that is used to review pleural fluid for analysis. This is under diagnostics. I think we're seeing this done. Have a lung biopsy, a bronchoscopy, a chest x-ray, or a thoracentesis. What do you think, Sam? Give me one. B, thoracentesis, have you seen this?
No.
Okay, so a big old needle is put into the pleural space and it can drain off any accumulation that's sitting in there. It can be quite dramatic, like liters of fluid can be sitting in your pleural space. Is that a normal finding? No, so we'll talk about chest tubes here soon as well. So they would need possibly a chest tube to help drain them. We can have just fluid, you can have blood, which we call hemothorax, or we can have air, pneumothorax. So this is talking specifically about fluid that they may be setting off for diagnostic purposes. Sometimes this can indicate like we got cancer happening, not necessarily lung cancer, but some sort of cancer. If you have these recurrent pleural effusions, what we call them. So they'll go in with this big old needle and drain it into plastic containers now. And send it off for analysis. Okay, lung biopsy, what do they do for that? Yeah.
Take like lung tissue and it's
Help identify for time out cancer or something, can be a tumor sitting in there. So we usually use that by using the bronchoscopy. It's just a tube that has like a little, you grab like little bits of tissue, or you can grab like a penny. Someone swallows a penny. It gets past the airway, down into the lung itself, or closer to the lung. They can go down and grab it out, right? Okay, so thank God for bronchs. And then chest x-ray, we talked about that, thoracentesis, awesome. The nurse correlates which of the following assessment findings to age-related changes of the respiratory system for an older adult. I always ask these questions. On your exams, I will ask every system we're in, I will say, how is this different in the older individual? How is this different in a little peds? All right, so do we have decreased airway reactivity? Decreased chest compliance? Decreased intercostal strength? Increased risk for hypocapnia? And decrease in macrophages in the respiratory tissue? We actually have increased airway reactivity. That means just how kind of sensitive is it, you know, to like, you know, they will cough more, but their cough is weaker. They'll react to like stepping out into the cold air. They will react, those airways will react more. Decreased chest compliance. It's true. Yeah, things get stiffer. Decreased intercostal strength. Also true. That's why pneumonia is a big deal. You don't have any kind of good muscle strength to help with that effort. Increased risk for hypocapnia. Actually, increased risk for hypercapnia. So increased CO2 levels rather than low CO2 levels. And then decrease in macrophages in the respiratory tissue. That is true. Do a little ABG interpretation for me. How do you interpret these arterial blood gas results? We have a 7.45. So what are we gonna say this is? Acidosis or alkalosis? Awesome. And what is my? Let's see, did I give you PaO2? Oh, no, okay. So we're not. Oh, yeah, I do. PaO2 is 78. Do I have an oxygenation issue? A little bit, right? Maybe my O2 sat is 92. Maybe low. Right. 89. So we'll put on a little oxygen. All right. PaCO2 is 30. So what should it be?
Yeah.
35.45. Well, that's lower, right?
No,
And my bicar is 19. What's that?
22, 26.
So what do we got? Why is this confusing?
Well, there's compensation happening, so you kind of have to like think about it harder because the levels are out of whack.
What do you think it is?
Well, it should really happen since because the pH is low and the pH is high and the pH is CO2 is.
So it's working in opposite direction. Or. And then this is lower. What do we say about, remember the Rome acronyms? Right? So respiratory works in opposite directions. So my pH higher than 7.45 and my PaCO2 is less than. Call that a respiratory situation, right? And then if it's a metabolic issue, they go in the same direction, meaning if my pH is higher than 7.45, then my bicar would be going higher. But do we have compensation happening? Yeah, I mean, how do we determine whether there's compensation? We look to see if they're all out of whack. Are they all one out of whack? Yeah, so what do we call this? Partially? Yeah. Isn't it like the kidneys are trying to work, but maybe there's something happening with the kidneys, you know? The ones I'm going to ask you are going to be very clear. But just know, on a real patient, they generally have more than one thing happening. So yes, we want our kidneys to kick in. But what if they have renal failure on top of a pneumonia, on top of a COPD? So, yeah.
So why would that be fully compensated? Because I know the pH is a little bit high, but.
Oh, yeah, sorry, it is 7.45. Yes,
Okay.
yeah, sorry. I thought it was 7.46. Yeah, you're right. 7.35 to 7.45 is what we're trying to get back to. When we see that, we would say it is fully compensated. Sorry. That was 7.46.
So is the pH normal? Does it matter that the PaCO2 is also normal? Because I thought fully compensated was being abnormal, or both the PaCO2 and bicar being abnormal.
Yeah, I think we're just barely there, you know what I mean? Yeah, so like, okay, it's happening, but. I wouldn't get. But I just don't know, in real life, it can be a mixed picture where you're like, oh my gosh, what is happening? Because if I have kidney failure, they are able to obtain those hydrogen ions or get rid of bicar. Good job, good job. Okay, let's talk pediatric respiratory conditions. You mean so fun? Okay. There's only a couple of them, right? Joke. One. Okay. Gonna do that. Alright, so I'm gonna give you a little scenario. Go down. You go down. Read through that. Figure out what you think. That's it. Read that through.
Sounds like- Wait, you guys saying tonsillitis too? I'm saying tonsillitis.
Okay, so then
Read it.
like this,
Read it.
scenario two, come on up to the front of the class.
You guys have white spots. Isn't that, it's not mono?
I think
The
it's
drilling,
this.
the drilling gives it away.
For what?
The drilling,
For what?
the drilling gives it away.
For what?
I don't know.
I think it's because look,
I think what that is.
Wheeling, inspiratory, Strider.
Hurry.
I think I.
Well, yeah, I looked at my notes, like, when I'm a sugar here. Yeah, I knew the drilling was the way that.
The drilling, yeah.
I
told you, drilling, I was like,
Oh, yeah, yeah.
Literally.
What's the one where you're not supposed to look down the? Like you're not supposed to- Which one is it for? I don't know about, oh, really? It's something like that, something like that.
Not yet. So people with the white sheets are gonna read their little scenario. And the people holding the card has to identify which one they have. All right, so we will help you. All right, Ms. Reagan, go ahead.
Alright, scenario, a 7-year-old presents with sore throat, fever of 102, difficulty breathing through the nose. Child also complains of pain when swallowing. On examination, the tonsils are enlarged with a white pus-filled spot on one of them.
Key symptoms?
Sore throat, pain with swallowing, fever, enlarged inflamed tonsils, and possible white or yellow exudate on tonsils.
Oh my gosh, so who thinks they have that? Who's holding the card that you think matches that scenario? Nope. You've done the hard work. You've done the hard work. They gotta figure it out. Yeah, who has what? Help them out.
Can I say what it is?
Yeah.
Oh, strep throat.
Okay, another name for that? Tonsillitis? Does someone have tonsillitis? There you go. Awesome. Come on up, partner. Okay, so what are the key symptoms of strep throat? Pus on the tonsils or in the back of the throat. Enlarged lymph nodes, this fever. Redness, so erythema in the back of the throat. Difficulty swallowing. Have you all had strep throat? Yeah, no fun, right? Okay. So what do we do? How do we diagnose strep throat? What is that swab thing? What are they doing?
They getting that music melody back, you know?
Yeah, they grab that culture that you saw how to get in your wounds. That's the same thing. They're doing a culture of the throat, right? So a throat culture. I always think of my little pediatrician's office. There were 5 of us in my family. I was the youngest, so like think of like 5 people standing up against a wall. I'm not sure this is totally exactly what you would do, but she was like this. So against the wall like this, throw culture, done. Throw culture, done. Throw culture, done. Cause all of us are probably gonna have strep, right? If one of us had it, all of us had it. So I'm not sure we use this approach to hold them, but just know it does cause people to gag and it is uncomfortable. So the quicker we get in there, but you're trying to get where that secretions and white patchy stuff is to determine what kind of bacteria versus a virus. Okay, awesome. So that's tonsillitis. How do we treat that? Antibiotics, bacterial, right? Yep, if we're talking strep, yes. What kind of supportive measures can you offer? Yeah, cold maybe, or like warm. Sometimes that feels good to people just be able to swallow. For the, yeah, say it again, sorry. Yeah, soft foods, easy to swallow foods, good. Maybe a little Tylenol or ibuprofen to help with discomfort, swollen lymph nodes, yeah, awesome. Good. Good job. You can head back, I'll keep my little card, so that's tonsillitis. What does tonsillitis, could it be mistaken for? What's right next to the tonsils? We're reviewing our anatomy. Larynx? The larynx, we can have laryngitis, we can also have pharyngitis. So if we're just talking about the pharynx, that's the throat itself, or are we talking about the tonsils? Sometimes they combine the 2 names, saying nasal pharyngitis, tonsillitis. So it's so close to each other, it's just like inflammation in that particular area, right? We're gonna stick with that. Okay. All right, what, yeah?
5-year-old is suddenly unable to swallow and has drooling, fever, and severe sore throat. The child is sitting upright in a tripod position, and there is stridor upon inhalation. The throat appears red and inflamed upon inspection. Key symptoms of difficulty swallowing, fever, severe sore throat, stridor, and tripod position.
And I would say drooling.
Oh, it's a day.
Yeah. That was not on there, but that's, yeah.
I think it's show.
Okay, so this patient is, do you think like this is someone I can take my time with? You know, they're sitting up in tripod, they have stridor. No, you're like, you are at risk of losing their airway. So don't lay them back, keep them in that position of comfort. Am I going to take a tongue blade just to see like, I wonder if this is strep?
No.
Because it seems like it could be strep. What happens when I push my tongue blade in there? You include the airway, right? Or if I put a culture swab in there, you can include the airway. And then how do you ventilate someone if you have no airway? You do not. You do not. Except we're gonna learn actually bag valve mask, or like CPAP, or intubation, or trachs. Okay, so there are ways, but we don't want to do that to this poor little one. How old is this one?
5.
Yeah, 5. If I looked in there without putting anything in there, it would be bright cherry red. And they're drooling because it's so swollen they can't even swallow their secretions. What is this? Who has?
Epiglottitis.
Awesome, epiglottitis, come on up. No square, didn't even do it on purpose. Good job. All right, so what do we do for epiglottitis? Yeah, anti-inflammatory kind of supportive measures. It's like we said, keep them in the upright position. Cool mist, maybe keep the inflammation down. We do not want these babies getting upset or crying because that also can cause us to lose their airway. So whatever keeps them calm is what we want. If that means mom and dad holding them the whole time, that's what we're gonna do. If they require oxygen for supportive measures, we may have to put in little airways, but just know that this is an emergency if they leave their airway. Yeah, awesome. Good job. Good job.
Yay.
Thank you.
A 4-year-old has a high fever of 103.
Oh,
severe cough, difficulty breathing, and the child appears very ill, has a harsh barking cough. This is also evidence of respiratory distress and loss. Key symptoms are high fever, severe cough, hoarseness, respiratory distress, bark coughing, and thick secretion.
Yeah, okay, so let's put in that thick secretions, cause there's 4 of these conditions that fall under this umbrella term. And, it seems so similar to all the other ones, right? So I think these thick secretions seen on the back of the trachea. If we took an X-ray, we can see that as well. Who thinks they have this one? Yeah, good job. So this is the type of group. Come on now, good job. Acute tracheitis. So this is a type of group. So they're going to have maybe that characteristic barking cough. The distinction between the others is the thick secretions. Okay. There's 4 types of groups, so we have to kind of be able to distinguish between them. What do we do for this? I have no idea. So if it's bacterial, we can treat with antibiotics, but it could be viral. So then again, supportive measures, trying to keep those secretions thin. So maybe lots of fluids if they tolerate it, but they're probably not feeling like drinking too much. So be checking their INO status. Maybe humidified air, keep inflammation down. Ibuprofen, Tylenol, watch their livers. And then, yeah. We'll talk about the other kind of groups. Thank you very much. So acute tracheitis is a type of group. Awesome. And what do we got?
All right, a 6-month-old baby presents with a low-grade fever, labored breathing, and a harsh, noisy cough. The child's respiratory distress increases at night and they are noticeably agitated. Key symptoms, harsh, noisy cough, often described as seal-like, labored breathing, low-grade fever, and increased distress at night.
Oily days. Yeah,
Acute spasmodic laryngitis.
that's what it seems like. I know. There's one like that. Yeah. And it's another type of group, so hold on to that because that's coming. Acute spasmodic, I'll tell you how to kind of tell the difference between that. This is probably one you don't really want to have to say because it's about as long as the whiteboard. Yeah, good job. Who has that? Laryngeotracheobronchitis, LTB, awesome. All right, Miss Courtney, good job. So this is another type of group. This is probably the most traditional, like when we think of group, this is what we think of. All right, so we have that tracheitis, which is like this, but it has just thick secretions specific to the trachea itself. This is the whole thing, the larynx, the trachea, and the bronchus being affected. They have this very distinctive cough. Sounds like a brassy, seal-like cough. Has anybody ever heard this? Hey, I can't even do it. Like yeah, it's very distinct. When you hear it, you'll be like, oh my gosh. Oh my gosh, okay. So this, when I think of group, I think of LTB. All right, so now, who thinks they have spasmodic group? Again, do you want to read that for us so we can kind of tell the difference?
A 3-year-old presents with sudden onset of a barking cough and difficulty breathing, usually in the evening. The child is calm between coughing episodes, but becomes very distressed during coughing episodes. Key symptoms are sudden onset of a barking cough, difficulty breathing, coughing episodes mainly at night, and calm between episodes.
Okay, so the difference between this one is that they appear healthy and well during the day, and it is at nighttime that they develop this barky seal-like cough with maybe no other symptoms. So you're like, that's so weird. This is where Remember in the videos, like I was saying, like the parents are like, oh my gosh, we're going to the ED, cause it's so like startling, and this happens when they're sleeping. So they wake up and they're having this seal-like cough, and they're like, oh my gosh, we're going into the ED. They take them out into the cool air. They're like, stops. So by the time they get to the hospital, they're not coughing anymore, they're not in that distress. So then they go home and put them back to bed. And then they do it again. They're like, oh my gosh, okay, we're going to the ED. And then when they get out in the cool air, it stops. So it's very specific to nighttime, and during the day, they appear healthy. Awesome. Whereas this, I know it's at night, but it's all the time. It's not just at night. It is happening during the day and at night. And they are sick. They don't appear healthy like this. That's what makes me. Yeah. Awesome. Then
Okay, a 5-year-old presents to the clinic with a runny nose, mild sore throat, and sneezing. The child has a low-grade fever for the past 2 days and feels slightly fatigued. The parents report that other family members have had similar symptoms. Key symptoms: nasal congestion, discharge, sneezing, mild sore throat, low-grade fever, and fatigue.
good job, Grace. Nasopharyngitis, also known as a cold. All of us probably have nasopharyngitis happening right now, right? All share that, like you have a little congestion, maybe a little low-grade fever. Except that sound roncorous, like that cough just sounds like a roncorous cough. I would suction if you were not able to get that out. No, you're good. You're good. On cue. Good job. Yeah. Awesome. Is everybody okay? That's just a common cold, very kind of vague, not too extreme of symptoms. Okay, awesome. Keep going.
12-year-old complains of pain and itching in the left ear after swimming in the pool for several hours. Which are reports of the full tenderness when the ear is pulled, or the outer ear canal is touched. These symptoms are ear pain and itching, firmness or discomfort in the ear, tenderness when the ear is touched or pulled, and there's exposure.
Oh my gosh, you're like, please ask this one. Please ask this one. What is it? Yeah. So you're like, okay.
Be hesitating.
Yeah, so this is when people are supposed, anybody have this? Otitis externa. So we're talking about the outside of the ear being kind of red, dry, and inflamed. Yeah, what can you do about that? Get eardrops, but also like cleaning with like not hot water, but just kind of tepid water. Put on like hydrocortisone type cream as well, bring down the swelling. We just don't want to break open and cause infection. Yeah, you're like, please put this on the test and say that this is a swimmer who swims all the time. Yeah, okay, awesome. Okay, it's certain thank you for that.
A 3-year-old presents with a fever of 101, irritability, tugging at the right ear. The child has a cold for the past several days. On examination, the right eardrum appears red and bulging. These symptoms: fever, ear pain, or tugging at the ear, irritability, recent upper airway infection symptoms, and red bulging eardrum.
Oh my gosh, that is so classic. You're like, please tell me that. Red bulging eardrum, recent cold, now they're having tugging at the ear. What if they can't tug their ear? What if they're babies? What do you see them doing? Yeah, they're like rocking their heads back and forth. You're like, what is happening? Okay, so what do we call this?
Otitis media.
Otitis media. How do we treat otitis media? Did you have the card?
Yeah, you gave me both.
What? We should go buy a lottery ticket. Okay, how do we treat otitis media? I've gone back and forth, honestly, whether we are treating with ear drops, like ear antibiotics, or like oral antibiotics. If it's recurrent, then yes, but if it's not, then maybe no. Maybe supportive measures. Then if it's recurrent, we may have to look at T-tubes. Is that what you're thinking? Awesome. All right, take us home here, you guys.
A 16-year-old reports extreme fatigue, sore
Okay.
throat, and swollen lymph nodes. The child also has a mild fever and a loss of appetite. The tonsils are severely enlarged with a grayish-white coating, and there is a noticeable swelling in the neck. Key symptoms: extreme fatigue, severe sore throat, swollen lymph nodes, especially in the neck, fever, and large tonsils with a grayish coating and an enlarged spleen.
Oh, did you hear that at the end?
Oh, there it is. I was just waiting for it.
Oh, cause what could that sound like? The kind of grayish, but we're, it's white patches, or this is kind of gray patches, the fatigue. The age of this person. And then I throw in classic sign of splenomegalia. What is this? Mono, you probably have y'all had mono? You guys are the age group, so
I have
it's
not.
called the kidney disease.
I don't kiss.
Oh, it's passed in saliva. Okay, usually this is pretty self-limiting. However, if you have that splenomegalia and you are like a soccer player or a football player, you cannot be doing that while your spleen is in bond. Awesome.
A 4-year-old develops a sudden onset fever of 102, chills, muscle aches, sore throat, and a dry cough. The child also reports feeling very tired and has a runny nose. The symptoms started abruptly this morning. Key symptoms: sudden high fever, chills, muscle aches, sore throat, dry cough, fatigue.
Influenza.
You just again.
They're not me.
I've been okay.
You're going to have this on Wednesday.
Oh, you love to hear it. In my suffering. Hooray.
I will order this up while I finish.
I have to.
Okay, sounds good.
Things like this.
So I worked in the Philippines this summer. It's a pretty amazing trip. So my friend got home today, which was all day every single. But on the way back, hoping to stop at China. If you're wondering if you if China or Japan or like any of the surrounding, we figured that you probably traveled buddy.
Oh my
So
gosh.
we didn't know, like, we would have a long layover somewhere, and we didn't know maybe you would have like a recommendation to like